What's up, Gestalt Education Nation? Today's episode is brought to you by The Payday Practice and our good friends Jeff Langmaid and Jason Deach.
So how would Seth Gooden, Gary Vee, and Tim Ferriss create a chiropractic practice? The answer is in this book right here. So our good friends Jeff Langmaid and Jason Deach, they created the Payday Practice to basically show you how you cover your monthly expenses in one day every month. Guaranteed. Generating monthly recurring revenue in your practice can create financial freedom, eliminate chronic financial stress, and turn the first day of each month from damn, it's time to start over to payday.
Get a free copy today at www.thepaydaypractice.com. The Payday Practice will show you the exact step-by-step process that you can use to generate monthly recurring revenue in your practice. Get your free copy today at www.thepaydaypractice.com.
All right, everyone. Welcome to another episode of the Gestalt Education Show. Today, our setting is pretty special, Brett. So we are in Brett's most prized possession, his backyard. So I know you've been working on this for a while. It's kind of starting to come together.
Work in progress.
Yeah, absolutely. So today we're sitting down with someone very special. Someone that the first time I've met her this weekend. So Martina Jezkova. Is that okay?
Yeah, it is.
Close. Okay.
Yeah.
I was practicing beforehand, and I knew I was going to mess it up, but yeah, it was okay. So
one thing is to pronounce it,
Uh-huh.
and the second thing is
To spell it.
to spell it.
to spell,
Ooh.
and the meaning of Jezkova.
So what's the meaning then?
It's a hedgehog.
You gotta be proud of that. You gotta be really proud of
That's
that.
a subtle
I
brag.
am.
Yeah. Well, Martina.
You can call me hedgehog.
Okay,
if you want.
Hedgehog. Let's go. Martina Hedgehog. Well, Martina is an international DNS instructor. You're a physiotherapist in Prague. You own your own yoga studio. You have your own practice in the Czech Republic. Not only that, but the thing that fascinates me the most is that you just told us you passed your final exam with Vladimir Yanda.
Many years ago.
Yeah, and
it's
not
like
only-
a dinosaurus history.
And not only that,
Before we
but-
get into that, the other close thing that Martina and I have, I was an intern at Dr. Skagg's office.
Oh my God,
And
yeah.
she was visiting Clayton at that time. So I'm an intern. I remember this. She told me today I was studying a big old whiplash book.
Yeah.
And
That's true.
and she was studying an active release book.
Yeah.
And so that was the first time that we came together. And so
It
I
was 21 years ago.
21 years ago. That is hard to believe,
Yeah.
Martina.
That's
That
crazy.
is- that ages us both right there.
Well, so then let's kind of start from the beginning, Martina. So not only were you able to learn from Dr. Yanda, but Dr. Lewit was one of your biggest mentors and someone that I know you hold very close to your heart as far as clinically and personally. And so Brett's told his awesome Yanda or Lewit stories on this podcast many times, but do you have any, just tell us about
Some of your
Lewit.
favorites.
Yeah, tell
one
us some of your favorite
favorites.
stories and talk about your connection with him.
It's difficult to pick up the best one because I have so many stories with Professor Lewit, and all of them I just take close to my heart. But I remember he was very curious about his students. He always took care of his colleagues and students, so he was guiding them. So when I was working in a Motol as a physiotherapist who started practice, he was knocking my door, just come to my room, I have interesting patient, just come and watch. So very often I was welcomed to his room, and when I was in his room I was assessing the patient. So he was checking how I was assessing, how I was treating.
Wow.
Yeah. And
How'd you do?
sometimes well and sometimes not well. So it came to that, point when I did something. So Professor Lewit told me just do this and that, and I did, and he slapped me over my hands in front of the patient, and he said, "You have both hands left-handed," which means in Czech expression, like you are not
very good.
not very good in palpation or in treatment. So I was so embarrassed. So I just disappeared for a couple of days, and I didn't walk in his room at all. And then 2 weeks later, he was knocking the door again. Come in, I have interesting patient. So he forgot completely. He was a great teacher, so he taught me a lot, actually.
I've heard from numerous people from all different parts of the world that his palpation was very light compared to whether it was joints, trigger points, soft tissues.
Yeah. His hands, if you touch the baby's hands and you have the feeling of the soft skin and soft everything, his hands were like that.
Wow.
Very soft and massive. Like the hand was so massive. So his palpation was amazing. Yeah.
What did you learn from Vladimir Yanda, who was another one of your teachers?
Oh, yeah, he was my teacher at university, actually. So I learned from him only at the university.
Wow.
He taught us partially, but I did a final exam with him. It was quite stressful for all of us, because he was very strict. And I remember that time he was a little bit tricky with all the students. He tried to get them on the edge of their knowledge, balance. He wanted probably to see how they are doing when they feel not comfortable. And it's a funny story, because he asked me a question which was not related to the questions I just picked up for the final exam. But he asked me a question about if I see the patient lying on the belly. He asked me the question, what does it mean, pseudohernia, abdominal pseudohernia? And that time, which is like 30 years ago, no, not 30, 25 years ago, I didn't know anything about DNS. But I already had my kids, like twins, and I did Vojta treatment with them. And I knew when they lay down on their bellies, they had, we called it in DNS bulging right now. The missing activity of transverse abdominis. So that was the only link I could put in between his question, like, what is the abdominal pseudohernia, and my observation with the kids. Wow. So I just said, I don't know anything about the pseudohernia, abdominal pseudohernia, but I can try to figure that out. So I started to talk about the abdominal wall and the missing function of transverse abdominis. So when patients are lying on the belly, so their pressure protrudes to the sides. And he said, oh, great. I like that. That's exactly what I wanted to know. So I passed the exam just because I was lucky. I had the kids, and I observed the kids. I observed the babies, and I give them the treatment. And I even didn't think that a couple of years later I would be a DNS instructor teaching intra-abdominal pressure and transverse abdominis, teaching bulging of abdominal wall, and this was Yanda's pseudohernia.
You wonder too if they were describing, we call it sports hernia here in the United States. You know that diagnosis?
Yeah.
Might be, you guys were on to something, way back when.
Yeah.
There's some legendary stories about Janda and Lewit and like them actually like during a seminar setting kind of getting into arguments. What were both of their strengths, their weaknesses? Like what did they have disagreements about? What were some of their main points of contention?
I don't know about that period so much because I was a student, so I was a little bit I was a little bit young, but I know they did not agree with some of the things. I think they were talking about the same, but from a different perspective of view.
Right.
Yeah.
One story I heard is that, Lewit was a big proponent of like doing towel exercises, for example, but Yanda felt like, that was more of like a compensatory strategy. I guess my question is, do you think there's a place for both of those strategies? Or
Yes.
are you, yeah. Right.
There is always place of both,
Right.
for both. Yeah, both
And
of
then
them.
what do you think? Are you still using Yanda's sensory motor work?
Yes,
are
I
you still
do
using
a
wobble
lot.
boards? And
I do a lot, and I think it's very helpful for all the patients. And even at the Charles University, I'm teaching the sensory motor stimulation for students.
because I think we've all been so mesmerized by Pavel, who's just the most amazing clinician in the world, that sometimes it's easy to forget about Yanda and Lewit and, you know, some of these foundational concepts that they enlighten us with.
No, we never should forget those things.
Yeah.
And we always have to applicate those things in a DNS.
Right.
DNS is just a neurophysiological concept that can be applied in any, like a method, in any technique. So
Right.
even you mentioned ARTs. So even you do ARTs, you can activate kind of like the stabilization system.
Right.
So the sensory motor stimulation should be never ever forget, as
Right.
well as the manual techniques like soft tissue release, etc.
So does that mean, are you still using wobble sandals even, or you're using wobble boards, rocker boards, or you just kind of,
I
Depends on the
actually
case.
do not use the sandals much.
they're kind of a pain. You got to have the right size and
Yeah,
Yeah.
but I still use them for the students to show them what they can activate. Yeah, so it's still unstable board, the sandals, because you have the half ball below the sandals.
right.
Yeah, so it's unstable. The good thing is you can walk. So it's not static. If you are on the board, you have to do static positions, kind
Right.
of like, yeah? So you can walk, but the foot is not flexible. Like the heel strike and the take off of
It's
the
rigid,
toes,
yeah.
it's a little bit rigid.
Yeah.
So you can activate the short foot, but I actually a little bit change my teaching even in a short foot. But I think Professor Yanda would agree with me. I hope so. So it's a
he's
little
not
bit,
here, so you're
He's
not.
not here. Yeah. But yeah, so you can activate a short foot in the sandals, but it's still rigid, kind of the foot. Yeah.
And you have been with DNS since it started in its
Yeah.
existence. So, can you give all our listeners maybe an argument on why developmental exercises are so critical in rehabilitation? Because one of the stones that people throw in us who don't know DNS is, well, why would we return our adult patients back to these, exercises in the first year of development? So give us a really good argument on why that is actually important for us to be implementing.
Okay. The first thing is that I usually do not have to explain that to my patients. They just do what
Disclaimer.
Yeah. They just take it as
They just do it.
exercises. They just do it. But if you have such a curious patients, I would say the developmental positions are actually originated in our brain software,
Right.
the function. So the programming is already in the human's brain. So we went through the ontogenesis when we were young. So the brain recognizes the supporting points, the movement patterns. So it's actually easier for the brain to recognize and clean up those pathways.
Right. Good answer.
So it's very physiological, very natural movement
Right.
for us, because the exercises are not only the muscle exercises, muscular exercises, they are exercises of our central nervous system.
Right.
So we are actually creating a new pathways, or we are cleaning the pathway that
Because I think it's a good
messed
point, because
up.
everybody looks at
Yeah.
exercise as just, I need to strengthen this. And that is not really DNS's hallmark. It's creating patterns. It's waking the nervous
Yeah.
system up to those
Yeah.
neural pathways,
Yeah.
and then
Yeah.
strength just becomes part of it.
Yeah, exactly.
Yeah.
It's the secondary effect.
Yeah, and our critics, they also say, well, DNS does not have an algorithmic approach. It's not cookie cutter. So can you explain why it's important that we don't fall into the trap of just saying, okay, this patient needs serratus anterior exercises, do these 3 exercises?
So I didn't get your question. So can you ask again? Sorry for that.
So like in the United States,
Yeah.
it's very common for people wanting a very cookie cutter approach to rehabilitation.
Like a cookbook.
Yeah,
Like
with
step
this,
1, steps 2,
yep,
steps
with
3.
this diagnosis, you do these 4
Okay.
things, and your patient's 100% better.
Okay. Of course, this is easy for everybody. You don't have to use your creativity. You just have the cookbook you follow.
Yeah, you
you
don't
can
use your
read
brain.
it. You don't use your brain.
Right.
So I used to say, use your fantasy. But some people in Australia, they told me, don't use fantasy. use imagination.
There's a sexual
So
innuendo
exactly.
there.
So I didn't know that as a not native speaker. So use your imagination. So you have to be creative. So there is no cookbook because every patient is very individual. So you can't cook according the universal cookbook.
Right.
So if you give the same instruction to 3 different patients, they will do different things. So you have to have idea about what you want to activate, but the ways how you get that activation, there are so many. And
Right.
for each patient will be the best different.
You had a great quote today. I think you said something like, the muscles in the body, they tell a story. So
Yes,
if you're
always.
observing something and, that's an observation gets, in the evidence-based world, that gets, cut down also.
Yeah.
So can you explain the importance of us being able to observe movement or observe muscle tone or overactivity in
Oh
our
my
in our
God,
patients?
it's so important. So when you look at the patient, empty glass.
I need a refill. Sorry. Before you start going, I can't wait to hear this.
That's okay. So when you look at the patient, that's what I learned from Professor Lewit a lot. Professor Kolář, Pavel Kolář, he also mentioned that a lot, and he teaches that you should be able to look at the patient without knowing the history. And the body tells you the story. Even the static positions or even the dynamic positions, they will tell you the story.
Right.
So you can try that on your own. Yeah.
Right,
So
right.
just to make a diagnosis or some tests, just according observation, and the body never ever lies.
And I think early on we were so mesmerized with Pavel's ability to work up a patient, not know what their history is, not know what their image findings are, and still being able to predict what that is. And that's basically what he was doing, wasn't it?
Yeah,
Yeah.
it was actually. He was able to understand the body language.
Yes.
Yeah.
Yep.
And that's also what I learned from Professor Lewit. So he always mentioned, like, you should not look at the x-rays first. You should ask the patient the history. You should assess the patient, and then maybe in addition, the last thing, look at the x-rays.
So
And because of the technology is going so fast, it improves so fast, we are almost like pushed to use the technology. So very often it happens that the medical doctor looks at the x-rays only, and he doesn't look at the patient at all, which is a problem of, I think, the modern
You talk about
history.
2 ends of the continuum too. So you have Lewit, who is really, really big on getting a very thorough history. James Syriac's, other people, in the world of manual medicine were really big on the history. Whereas Pavel's a little bit the opposite. He almost wants to assess the patient and then not be maybe biased by what the patient's saying. Let the body tell the story. Maybe it's that Pavel's wanting to just get better at it, himself every time he sees a patient. What do you think about those two?
I think those two things, they just belong to each other.
Yeah,
you can't separate them. You can't separate them. So I think if you do both, you are a great clinician.
Right.
Yeah.
Love it.
And good. Pavel does it as well. So even he presents like that, so he does also all the stuff you mentioned before.
Right. Yeah. Perfect. Martina, you are considered to be one of the top people in the world with pelvic floor function and dysfunction. So
not sure about it.
just wear it. Just wear it.
It's like a strong word.
Yeah. But it's interesting. People take DNS courses and they wonder, once we get this inner unit of muscles, which most of our listeners are going to know about, is that good enough, or do we need to be doing very specific things for the pelvic floor? The research is interesting. It tells us this inner unit of muscles, all these muscles kind of coordinate and work together. But do you think, is there a time where we need to specifically focus on only pelvic floor exercises, or what is your current thought process on the pelvic floor? Because I know you've thought long and hard about this.
The pelvic floor, I think, is a very crucial muscle group. They belong to a deep stabilization system, and they are very often forgotten or neglected because we don't see them. So it's difficult to find them, to be aware of their function if we don't touch them or if we don't see them. Mm-hmm. So that's kind of like something that is a little bit
out of
forgotten.
sight, out of mind, basically.
Yeah.
You may not be seeing it, but it's seeing you, as Thomas Bird just told us.
Yeah. But they are actually included as a stabilizers in a posture. So without pelvic floor muscles, there is no movement, no posture. So they are very important part of it. So we should not forget it.
When we talk about, like the diaphragm being like a piston is descending down, we have eccentric activation of the abdominal wall. What is the pelvic floor doing functionally, and what's it actually doing physically? Is the pelvic floor also moving when we generate intra-abdominal pressure?
Yeah, it does. Yeah. So actually the pelvic floor is doing the same thing as the abdominal wall is doing. So when the diaphragm goes down, the pelvic floor does eccentric contraction. So, and it has to regulate the intra-abdominal pressure as well as the abdominal wall.
Right.
But the pelvic floor is under, I would say, a bigger load, bigger challenge to maintain the organs at the same time in the physiological position. So if you imagine a trampoline, you may have a new trampoline that is nicely springing, and you may have an old trampoline that is losing his function, or you may have a too strong trampoline that is not springing and it's more like a wooden board. Yeah. So those two last examples, it should be on the pelvic floor. So I always say that the pelvic floor must be juicy. Juicy.
Which of those two create the most problem? Is it kind of one and the same, or is one worse than the other?
No, they are the same. Yeah. So you may have a weak pelvic floor, like a hypotonic pelvic floor, but you may also have a hypertonic pelvic floor. But both, like types, they create trigger points and dysfunction in activation. So it's not enough just to train the pelvic floor in concentric and eccentric contraction, but you have to also load the pelvic floor in a gravity field, plus you have to integrate the pelvic floor into the global motor patterns, which means that you start to use the ipsilateral or contralateral pattern. So one side of the pelvic floor has to do eccentric contraction, the other one maybe concentric, or there is a muscle pull to the right side or to the left side. So juicy pelvic floor. Yeah.
And then, how do you, from an assessment standpoint, know whether or not the pelvic floor is hyper or hypo? I mean, what's your way of knowing that?
Usually I can see a little bit from the superficial muscles.
Right.
So, for example, some activation of external rotators or paraspinals or abdominal wall, they can give you some story if the pelvic floor would be dysfunctional or not. I can't say hypo or hypotonic, so because I have to touch.
Right.
I have to touch externally, like the coccyx or along the ischial tuberosities to touch the pelvic floor, or then I do the internal work as well, which is the most exact assessment and work.
Does internal assessment make its way into every assessment for you, or when do you pick and choose to maybe go down that route, or when do you feel like that might be more important than other times?
Yes. If the patient comes with the pelvic floor issue as the main issue, like incontinence or pain or whatever, I usually do the internal assessment at the first visit. If I have a low back pain patient or hip problem patient, I usually assess externally the pelvic floor. Then I do some external work or some support for the pelvis stability, which also helps the pelvic floor to be better integrated. But I just keep kind of distance just to go in every pelvic floor internally. So I just have to.
You don't really want that reputation, do you?
Some relationship with the patient to be kind of familiar with him or with her, and her with me as well, to feel more comfortable for the internal pelvic floor work.
If you saw 100 patients
Yeah.
who were deemed having pelvic floor dysfunction, of those 100, how many would require internal treatment, in your opinion? Ballpark. It doesn't have to be an exact number. Is it a lot or is it not very much?
Not very much.
Yeah.
Not very much.
Right.
You can do quite a lot of work with external work if you are good in activation.
Right.
You even don't have to touch the pelvic floor if you are good clinician and if the patient is not extremely severe with the pelvic floor dysfunction.
And is there ever a time and a place for Kegel exercises? That's kind of the thing that we hear. And then, for the last 15 years, we've been telling people, we would never do Kegel exercises. Although in some of the research, there's been a resurgence of people kind of talking about that. And if you're not using Kegel exercises, what female or male cues do you actually use to get the activation that you want?
So Kegel exercises, I have get all times the questions about Kegel exercises.
Sure.
So I think whatever techniques you learn, you can partially use it in your practice. So even the Kegel exercises, they can teach you something. They can give you some idea how to activate the pelvic floor. I'm not saying it's totally bad idea, but we have to move on further than only Kegel exercises.
Right.
So pelvic floor is not only squeezing the pelvic floor, there must be also a lift of the pelvic floor. And we should not stay in horizontal positions, but we should go in more vertical positions, because we don't lie on our backs all day long. We have to sit up, we have to walk. And when we walk, one leg is stepping forward, so there is some muscle pull, and the muscle pull direction of the legs is followed by muscle pull direction of the pelvic floor. So there are a lot of things you need to think about when you want to make the pelvic floor functional.
So, in DNS, obviously we train squat, we train low kneeling, positions like this that will influence the activation of the pelvic floor.
Yeah.
is that enough, or do you ever use a verbal cue? Like, do you ever have like an internal cue that you want these patients to actually?
Yes.
Could you share some of your favorites? Like today, you gave an example of like, imagine pushing your kidney posterior laterally.
Yeah.
Do you have any of those like really awesome, just
quick
hitter cues for pelvic floor activation?
Yeah. I usually, or my favorite one is when the patient gets the feeling of when she or he supports on his feet, because foot support activates the pelvic floor if the legs are in the centrated position. Yeah. So when you push with the feet down to the floor, the pelvic floor is activated like a fountain up. So it goes like, which keeps your spine long, which gives you an upriding of the spine as well. And the pelvic floor is like a fountain, like a water in the fountain. Yeah.
Okay, and then I think the males are kind of neglected also in the pelvic floor.
God. Yeah. Oh. Not a very long time ago, I had the discussion with my colleague, and she said that she had a conversation with one of her client, male client, and she asked him to activate the pelvic floor, and he gave her answer, I thought the pelvic floor belongs only to females. Males don't have the pelvic floor.
The anatomy.
So we neglect the males, like this male was neglecting his pelvic floor.
Right.
So males also have a pelvic floor, and they need kind of activate the pelvic floor as well. Yeah.
What? Oh, go ahead.
I was just going to say.
Okay, I know your question now.
Lift your penis up.
No.
What verbal instruction you give
No.
the
Lift your
male
penis up.
patients?
I was going to ask, what are these male patients with pelvic floor dysfunction coming with? Like, what are they presenting with to you?
Usually they come with a pain in a pelvic floor around the coccyx.
Intraanal pain or somewhere along
Could
there?
be, or during the sex, having a sex intercourse. Or they come after the prostate surgery and they already have some weakness of pelvic floor and some incontinence issue, which is very common after that surgery. So, but you can also have a low back pain patient where you feel that the intra-abdominal pressure, it's created, but it needs a little bit of the pelvic, tilt like we did yesterday, a little, the last degree, and you can't get it without the pelvic floor activity.
That was today, by the way, just...
Yeah.
Martina is giving us a huge favor because our good friend Marcella, unfortunately, couldn't make it to the DNS Pediatrics this weekend, and so she is pulling... This is her 4th straight weekend teaching.
Yes.
We're keeping her out past her bedtime to do this podcast, and so if anything slips through the cracks, just give her a little bit of leeway, would you? So.
What do you think about... so we talked about, deep squat, low kneeling. Do you have any, kind of sleeper positions that maybe our listeners wouldn't think about that are good that you like for working on patients with pelvic floor dysfunction?
What do you mean, sleeper positions?
What would be a good that people wouldn't think of? Most people know that squat's a good place to work the pelvic
High
floor.
Kneeling, low kneeling.
Yeah. Do you have any other positions, DNS positions, that you really like that maybe our listeners might not be thinking about?
Just try sitting. So if you sit straight,
pay attention to the YouTube here, guys.
No, anterior or posterior pelvic tilt. That's good. I can hold it. That's fine. And you just keep your legs centrated. And if you gently start to push your feet down, you focus on 4-point support on each foot, and you relax. And you push the feet down. Can you feel your pelvic floor activity?
Yeah. Oh, yeah.
So any foot support,
right.
Even sitting, standing, squat, of course, because you load the feet a lot.
Sure.
the pelvic floor is massively activated, but even half kneeling position, when you kneel on one knee and the second leg is in a foot support or bare position, they are
All
great.
good.
All good.
Some people like cues of like imagining you're spreading your ischial tuberosities apart. Do you ever use any cues like that?
Yes,
or not?
I
Yeah,
do.
yeah.
It's for pelvic floor relaxation.
Okay.
Yeah, because if the ischial tuberosities, they go away each other, the pelvic floor relaxes, does eccentric contraction or relaxation. Yeah? Which allows you to bend forward, actually. So people, they can't do that pelvic floor relaxation, or they have a very tight pelvic floor, they actually can't bend so
Right.
much forward, because flexing the hips needs ischial tuberosities away each other.
Right.
Yeah, and if they squeeze the pelvic floor, they compensate the forward bend in a like lumbar spine or thoracic spine flexion.
Right.
Yeah.
And then do you do internal work yourself, or do you refer out for that?
On myself, if I
No,
do it.
on your patients.
On your patients.
On my patients. That was a
There's
question.
some low-hanging fruit for a joke there, but
No, I'm teaching the pelvic floor also to my patients as a self-treatment.
Right.
Especially the females, they can really well relax the pelvic floor like a manually, the internal work. So that was actually a good question
Yeah.
that I did not understand well. But I do it on my own with my patients. So
Yeah.
I'm familiar with that. So
And the prevalence is high. So the research says that 20% of postpartum females have a vaginal birth, have leaking with coughing, sneezing, laughing. So do you agree with that? That's kind of what the current research is saying.
It depends when the research was done. There can be some recovery issue, and especially what the ladies they have done after the birth.
Right.
So if there was a trauma, if there was a scar, if there was episiotomy done, or what kind of training they had after the birth. So I think there are so many things they may influence the function of the pelvic floor, especially after the birth, giving a
Right.
birth. So I actually can't
How about phrasing it?
confirm that.
Yeah, how about phrasing it this way? Of females that have a vaginal birth, how many of them deserve postpartum care? How many of them do they need pelvic floor attention?
I would say they should know after the birth that they should take care of their pelvic floor a little bit to relax or to activate the pelvic floor, to release the scar like a massage.
Right.
And we did a research with my student 2 years ago, and we just created a manual guide for ladies after giving a birth, and we compared two groups, about I don't know how many people we had, like hundreds, some hundreds, people in the both groups, and we compared the recovery of the group that followed just the our recommendations, but the written recommendations, not the manual therapy, nothing in like face to face. With the ladies, they didn't read those instructions and those exercises, and the influence was massive. So I think it's good to give them some introduction how to activate the pelvic floor, and for example how not to do the sit-ups, because we don't need to activate the rectus abdominis, so we need to activate more the transverse abdominis and pelvic floor corrector.
And then I'm sure it's getting more popular in Europe, but it's very popular here. A lot of females are going through a C-section. That
was another research we did with another student.
Yeah. So what
is better, if the vaginal delivery or the Caesar section?
Well, in the United States, why the women like the C-section is they can kind of schedule around it. So what are the things, if we have patients that are having C-sections, besides scar mobilization and things like that, is there other things we should be on the lookout for those?
Yeah, it's
Sublubrications.
an abdominal wall activity.
Right.
They will have some desensitivation or desensitizing
sensitization. Yeah, you got it. Yeah.
of the abdominal wall. And if you don't feel the abdominal wall, it's very difficult to activate.
Right.
And if you don't activate the lower abdominal wall, where the transverse abdomen is very important for the pelvic floor. They even may have issue with the pelvic floor.
Right. Is it becoming more popular in Europe or Czech Republic or not? Not really.
Not really.
Not really.
Not really. And we do our best
To not do
stop
it.
that.
Yeah,
To
right.
stop that.
Yeah.
Yeah. Yeah.
All right. Unless you got anything more on the pelvic floor. Yeah.
No, I don't. I was getting ready to switch gears.
Let's go yoga.
Yoga. So yeah.
we were talking to literally, you're a woman of many talents. My gosh. So in yoga, what were the problems with the original principles of yoga and Pilates that were originally taught that maybe you're not teaching now? We all know yoga and Pilates can be magical for the right patient, but I'm sure there's some things that you've kind of tweaked and changed along the way.
For those that don't know, you own a yoga studio. You teach a DNS yoga course. Yoga is very passionate of yours. I know, and you're. It's been a part of your life for many years. So continue with that question.
Couple of years. Yeah. I think people seek for yoga when they seek for mobility, and they
Stretch.
to stretch, to show the ego a little bit like,
Yeah.
and they are looking for Pilates when they look for stability more. So luckily today we have like a modern teachers. They already follow kind of DNS thoughts. So, but the original versions were more about like Pilates sucking the belly button in, creating the hyperactivity of transverse abdominis, pushing the lumbar spine back, more inflection. So in the traditional way of Pilates, you see more the flexion strategy of the stabilization through rectus abdominis, and they are actually very weak in oblique muscles activity. They are extremely strong in rectus abdominis, but very weak in oblique. So, and yoga is all, in an old way, is all about lifting the chest up, which actually creates the open scissors, like a position between the diaphragm and the pelvic floor, which is focusing a lot of chest breathing, but no movement in abdominal wall.
So that's a pretty big fundamental difference. Yeah. So do you think there's still a place? Because I've heard the argument for like some of our hardcore yoga and Pilates people that if you teach hollowing, you're teaching better awareness of the abdominal wall. Do you believe that, or do you feel like there is literally no place in yoga for teaching hollowing of the abdominal wall or sucking in the
There is a place, and you can even use it in like a DNS. If somebody is not aware about the abdominal work, you teach him how to suck and how to bulge.
Right.
Two opposites movement to get the neutral.
Right.
It's the same with shoulders. If somebody is here and you can't activate him to move the shoulder blades down in a caudal position, you just ask him to move them up a lot, and they can see the difference between their normal upward position and the higher position, and then they can find the caudal position. So you teach them two opposites to find the neutral.
Right, sure.
So even with the pelvis, if we wanted to have the pelvis in neutral, we do anterior tilt and posterior tilt to find and balance the neutral of the pelvis. So the same
to
is
kind of
with
feel the body,
suck in and bulge out. So to find the neutral, so you can use it. And there are also some positions like in yoga, they suck the belly button in and they pull the diaphragm up, which is called like Uddiyana Bandha, which is one of the like locks in the body. And I think it's healthy to do it for some activation, which is more deeper in yoga, but it should not be your pattern of stabilization.
Sure.
So you should learn neutral first, neutral of the TL junction, neutral of the diaphragm, the proper function of the diaphragm. So this should be your pattern. And then you should learn the skills, like the next steps.
Right.
It's like if you teach patient forward bends and back bends without knowing what is the straight spine, you don't get any results. First, you have to know what is the neutral spine, and then explore forward bends and explore the back bends. So first, you have to know your physiological diaphragm work, intra-abdominal pressure, correct breathing, and then you can explore Uddiyana Bandha to suck in, or some other activities of abdominal wall when we bulge out. But it should not be, so we should not be slaves of that pattern. We should master that pattern, if you understand what I mean.
So if I'm hearing you correctly, then you maybe, let's say a patient that is an avid yoga performer, they're coming to you through an issue. You may use DNS correctives to get them into better positions in yoga, but you're still trying to convince the principles across both matters, giving them the freedom to kind of express both regions or both types of thoughts. But then
actually, that was the reason when I started to study yoga, because I didn't have the answers for my patients. So they were saying, we were taught by teacher this and that, and I had the physio answers, but I didn't have the arguments from yoga. Therefore, I started to study yoga to understand yoga deeper. So now I can give them the answers.
Sure.
You know, one of the knocks on DNS has been that, you know, in life and function, the spine needs to get out of a centrated and neutral position. Obviously, traditional yoga spends time in more in-range positions if we're talking about the spine or even the extremity joints. Could you kind of help us reconcile those thoughts? Like when it is okay to flex the lumbar spine, or like in a cobra position to in-range load the spine?
That's easy.
Because it kind of goes against, you know, like what most people think about DNS. So yeah.
If you think about spinal elongation, which you learn in neutral, let's say supine, spinal elongation. So you create a space between every single vertebra, and then you want to flex the spine with the same idea, having the space between every single vertebra. Of course, the frontal part of the spine will coming closer.
Approximate?
Will approximate a little bit more. The posterior column of the of the spine will come a little bit more convex.
Sure.
But it should be even in every
shared
single
movement in every segment.
Yeah.
Right.
Yeah. Usually what happens, we overload couple of segments in hyperflexion, and then the other segments do not flex at all. So if we see that in a flexion, we should teach the hypomobile segments to flex more and the hyperflexible segments to stabilize more. The same is with back bends.
Is that hard to do in like a class setting?
No. No, it's not.
Okay.
It's actually not, because you show the students, so most of them are very visual, so you show a correct and incorrect pattern. And if you take care, or if you take attention to the diaphragm, if you do forward bend and you contract the abdominal wall too much, all your breath is going backwards, only backwards, and you don't breathe forward. Yeah? If you do back bends, very often, if you hyperextend the TL junction, that's a common compensation, you breathe only forward. You don't breathe backwards. So if you pay attention to your breath, to distribute it, not evenly, but at least a little bit in that contracted area, and the patients or the students in the class, they focus when they do the forward bend to breathe forward with the diaphragm, and when they do back bend to breathe backwards as well, you are quite sure that they will be in neutral.
Paul Hodges says it pretty well. He says when we talk about stabilizing our lumbar spine, there's 3 things that need to always be occurring: respiration, stabilization, and maintenance of continence. So in traditional yoga, do you think maybe the stabilization piece has kind of been left out, which is maybe what you're adding in now?
Yes.
So
Me. I think a good yoga teachers, they have a good feeling for,
because you hear the respiration piece, but you don't hear the stabilization piece much.
I would say I like the sentence, the forward bends are not about touching your toes. It's about of that things you learn on that way. So you always have to be aware what you are doing, where you are working. And I always say that yoga is not about the flexibility, but it's also about the stability.
Right.
And there is no stability without flexibility, and no flexibility without stability. Sure. So it always have to go together hand by hand.
And, literally for 60 or 70 years, people have been talking about the mental benefits, whether it's anxiety, depression, of like a yoga protocol. Are you incorporating that into your DNS yoga courses? Like, are you getting the same benefit that other people are in like a yoga strategy, which is helping them with anxiety and other
Actually,
meditation, things like that?
Yeah. It's, it depends if I do it in yoga courses. I do it in my classes, because my classes, when I teach the classes, it's 90 minutes class always. They have some physical exercises, but in the end we do pranayama, and I do some like a short meditation or shavasana, the final relaxation. And I use kind of meditation techniques. But the body and mind are very closely related.
Yeah.
So if you work physically and you work well, you can calm the mind into the meditative state. But also you can work from the other side. You can calm the mind to relax the muscles.
Wow, that's
it's
profound.
Like a brother and sister.
Sure.
Yeah. Like
You're
relatives.
like Lewit now with your quotes. That's impressive.
Beautiful. Man, I think we covered it all. We came in clutch there at the end with the yoga. And
can I add one thing? Because there was
please.
kind of a 3-legged stool we wanted to hit with Martina.
Yep.
The last thing was pediatrics. I just think the pediatric patient, at least in the United States, is the most neglected group of patients that is out there. Why is that? What can we do to change
probably
that? How
you
important
are
is it?
afraid of pediatric patients.
Right. Yeah. I think. Yeah, that's probably right. Yeah.
I will use a quote of my really good friend. He lives in Los Angeles. Mm-hmm. He has MS, and he's teaching MS classes around the world, or classes for MS patients. And he says always, you have to walk on the fine line between the courage and caution. Mm. This is, I think, how you should work also with the babies,
right,
with the kids. You have to be courage enough, but caution as well.
Sure.
Right.
Cautious as well.
Yeah.
So But if you understand developmental kinesiology, you just place the child or the baby in the developmental position, you gently resist or gently approximate, and the brain will find a function.
Yeah, that's well said.
Well, and I think too, I mean, Brett, you've talked about it for years too. It's the brain in those children are so adaptable that it doesn't take a ton of treatment to make big changes either.
They don't have a lifetime of joint blockages and trigger points and tension and tone.
And they have a plasticity of the brain, so they are flexible. Yeah.
Which I think is sometimes you get overwhelmed with, you have a baby that's a little fussy or, swerving out of the way and stuff. It doesn't take a ton of time under tension to change those tissues like it may take for a 40-year-old man or something like that. It just... I think you said it well, if you understand the developmental positions and then, if you add in some of the postural reactions that we learned today you are a force to be reckoned with.
Yeah.
Well, I think too, I mean, the effect, like if this whole system is not working well, the central nervous system is not controlling the muscles well, then our joints, our bones are not formed in a way that we would like. And I think a lot of people just don't, it's a hard concept to wrap their brain around.
It is. So many people, they just think we are born and we have the structure.
Right.
No, the structure is under the development, like continuous development. So until we are growing. Yeah. Still, when we are adult, we still can change a little bit.
Right.
The structure by the bone reconstruction, remodeling, etc., how we weight bear the bones, etc.
Yeah.
But the main changes of the structure we can actually support when there is a growing, like a period of the life.
And I think a good closing question for you would be, Martina, if DNS is approximately 15 years old, so we're basically in our infancy of DNS officially being started, what does this look like 10 years from now, 20 years from now? I mean, where is DNS going? I mean, what is your vision?
It's a difficult question. So you mean in the future?
Mm-hmm. Future.
I don't know.
Yeah.
I would be very curious about it. I hope we will just find answers for some of our questions, but I hope we will also still be respecting the old knowledge,
principles,
because very often if people start to improve something, make it better, they are disconnected from the roots.
Yeah.
So we should not forget all the golden stuff we have learned from old professors and great minds, I think.
Well, I think that's important too. As someone, as a young clinician, you two have years of experience on me, but I can feel the passion that Dr. Lewit, Dr. Yanda have had on you, and Brett's told stories and stuff like that. Maybe if I could just get you, before we close, I know we got to get to dinner here, but will you give us one of your most memorable patient encounters with Dr. Lewit? Maybe a patient story that you
where he pulled a rabbit out of a hat, just like blew your mind.
In closing, we'll put it this way. We're here for DNS Pediatrics. DNS is a part of Gestalt education that's very important to us, and it's the lens which we oversee all of our patients at Winchester Spine and Sport, and so we're thankful for the work you've done there. I'm buying time for you to think about a story here. We're thankful for the work that you've done, and we're so excited to hopefully host you back for some of your other courses. So.
You got to listen to this. We had Michael Shacklock on recently, the neurodynamic guy, and he said, we asked him the same question about neurodynamics, and he said it was so fascinating. He goes, 15, 20 years from now, he's like, hopefully it'll be about the same, meaning the principles are so good that they stand the test of time. And what he said, research is going to come out. It's going to confirm or refute what we're talking about. But something that is really powerful, the principles will always be there.
Yeah, exactly. Yeah. That's like a structure, like the skeleton that is supporting the rest.
Yeah.
Sure.
Yeah. I love it. All right.
Yeah.
No story. Well, We got to have her on again to tell that story.
That's right.
Then, maybe.
Well, we'll come up with
I don't know. I can't think
I can't
about
put you on
now.
the spot.
Sorry.
Yes,
Sorry,
that's okay.
I
It's been a
can't.
long day.
Yeah.
It's been a long
Maybe
long couple
tomorrow.
days. There we go. We'll add a little addendum on the end. So anyway, guys, I hope you enjoyed this conversation with Martina. We covered a lot of different things, pelvic floor to pediatrics to yoga. I think I couldn't agree more. The principles of DNS are here to stay, and I don't think they're going anywhere. I know it's a passion project of all of ours is to continue thinking about these things and to progress in them. So it's just a pleasure to sit down with you. So,
and people always have like a DNS bucket list, and Martina. Everybody says you have to see Martina at least once in your.
that's exactly right.
Whether it's a yoga or a female health course or a pediatric course.
Yeah,
So.
you did great. I'm so in debt too because we've seen Marcella, which we're partial to. We love Marcella, but to see it from your lens and to see your teachings, it's been pretty special. So anyway, guys, I hope you enjoyed this conversation. More to come just like this. As always, if you're interested in any of the courses that we host, gestaltedu.com/courses and
more on DNS, rehabps.com
Yep,
is where we
exactly.
learn more about DNS.
Exactly.
The website has gotten so good, I think.
the app with all the videos and
The online library, it is just amazing.
Absolutely. So, all right, guys. Martina, thank you. Thanks for
Thank you
sitting
very
down.
much.
Appreciate
Thank
you.
you.
Yes,
Thank you.
Oh,
Thank you.
well done.
Yeah,
So good.
Thank
Yeah,
you.
yeah.
Thank you.
I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.